We're still getting people joining in, but to get things queued off, again, Ilana Crum was supposed to be your chief today, but I'm stepping in. For those of you who haven't met me, I'm Alex. Alex Dragner's one of the VA chiefs. We have a great talk today from Dr. Maria Corcorran, who is actually one of our wonderful UW lifers who's been really, really well acquainted with our residency and things that we see. She's an ID physician at the UW Medical Center, and she's going to be talking to us about viral hepatitis today. I'll moderate the set, and just a reminder, these sessions are recorded, so you can catch them at a later date if there's stuff that you like to reference again. And it looks like everybody is muted, but just as a reminder, if there's a question, either put it in the chat box or and I'll ask it, or if it seems like I'm not answering the question, just raise your hand in the section. Okay. And with that, I will hand everything off to Maria, and I think I might have to make you a co-host.
Okay,
so
great.
Let me just do that. There we go. And so you should have the ability now to share your screen.
Okay, great. Well, hi everyone. It's great to be here with you today. I'm just going to share my screen here. Let's see. All right. Does that look good, Alex?
Yes, it does.
Great. So as Alex mentioned, my name is Maria Corcorran. I am a junior faculty in the Division of Allergy and Infectious Diseases, and did all of my training here at UW, so was in your guys' shoes not too long ago. And I'm going to be talking to you today about viral hepatitis. It's a big topic to fit into an hour lecture, so we're going to give you a little bit of a smattering of a few different viral hepatitis. Let's just advance my screens here. So I don't have any disclosures. The only thing I will say is I do have some pop-ups from the Sophos antivirus security that sometimes come up on my screen. So I apologize. I don't know how to fix those yet. If that happens, I will get them out of the way. So as I mentioned, we're gonna try and address hepatitis A, B, and C today. We'll discuss some aspects of global and local epidemiology, review risk factors, natural history, and diagnosis, and then I wanted to provide some guiding principles on management. So I think the purpose of this first slide is just to drive home the point that viral hepatitis, specifically hepatitis B and C, is a major problem around the world. So in 2017, the WHO estimated that there were 325 million people in the world living with either hepatitis B or hepatitis C, and that equates to about the population of the United States. 257 million of those are infected with hepatitis B, and 71 million are infected with hepatitis C. And the burden of disease, as you can see on this slide, in the darker shaded areas is really shouldered by the Western Pacific region and then Sub-Saharan African region as well. And so this 325 million is in contrast to about 38 million people infected with HIV. So a huge problem just based on the numbers. And there's also a problem in terms of mortality. So this is not just a chronic disease that people do not suffer problems from. There's quite a high burden of mortality related to viral hepatitis, with an estimated 1.34 million people dying of viral hep in 2015. The highest number of deaths, as you can see in the blue bar here, is due to hepatitis B, with the light blue area representing deaths related to hepatocellular carcinoma, and the darker blue area the mid blue area representing deaths related to cirrhosis, and the darkest blue representing deaths related to acute hepatitis. And then second to that is the red bar representing hepatitis C, of which the majority of deaths are due to cirrhosis, and about a quarter of which are due to hepatocellular carcinoma. And this is data, this is a graph that was published in the New England Journal last year in a review of chronic hepatitis B and C, and the data comes from IHME, or the Institute of Health Metrics and Evaluation here at the UW. And what you see here is this blue line represents chronic hepatitis B and C mortality. And that actually is estimated to outnumber mortality due to tuberculosis, HIV infection, and malaria at this point in time. And then these sort of dashed line estimates are what mortality may look like in 2040, at which point in time it's estimated that mortality from chronic hepatitis B and C could outnumber the combined total deaths of TB, HIV, and malaria. And so because of this high burden of disease, the WHO in 2016 released elimination targets for viral hepatitis, specifically for hepatitis B and C. And they called for a reduction in incident infections by 90% and a 65% reduction in deaths. And if you, talk to folks kind of in the viral hepatitis world, these are actually like, very front and center on people's minds. And there's a lot of efforts globally to try and reach these targets, although I will say that I think many countries, including the United States, are kind of failing miserably at this. So moving into kind of talking about individual viral hepatitis, I think viral hepatitis can be challenging sometimes because it's a bit of an alphabet soup with different modes of transmission. Some, viral hepatitis is chronic, some is not, some has a vaccine, some does not, some is treatable, some is not. And so we'll really break down some aspects of Hep A, B, and C in the following slides. So let's start with hepatitis A. So as this is transmitted primarily through ingestion of contaminated food and water or through direct contact with people who are infected. Typically this causes an acute hepatitis, and the acute hepatitis can be either mild to severe. And there's globally an estimated 1.4 million cases that occur annually. And in 2016, WHO estimated that there were just over 7,000 deaths related to acute hepatitis A. The burden of hepatitis A is really found in sub-Saharan Africa and kind of South Central Asia, with some intermediate prevalence of Hep A in Latin America and parts of the Middle East as well. Although we do have quite a bit of hepatitis A in recent years closer to home. As many of you may know, there's been a national outbreak of hepatitis A really dating back to 2016. 33 states have publicly reported outbreaks as of September 4th, 2020. And there's been about 34,000 cases across the country in the past few years. 61% of these cases have required hospitalization, and there's been 333 deaths reported to the CTC due to hepatitis A infection. And here in Washington State and King County, we are not immune from this outbreak. We've actually been having our own outbreak of hepatitis A really since January of 2019. But as you can see here on this graph, these are cases reported to Public Health Seattle, King County. There's been a steep rise in cases in the kind of winter and spring of 2020, with actually quite a few cases coming in right as kind of COVID was hitting as well. And it seems like based on this graph that cases may have tailed off a little bit in King County, but I would say that there's probably some delayed reporting just due to everything that's going on at the public health level with COVID. And so I think it's a little bit too soon to say if we've really gotten a hold of this. But since January 1, 2019, we've had at least 174 cases here in King County. Similar to the national data, about 62% of them have required hospitalization. And there's been 2 deaths, so about a 1% death rate. And most of these cases of hepatitis A are amongst people who are living homeless and or who inject drugs. So these are reported risk factors of cases of viral hepatitis A in King County. And you can see that this bar here kind of in the center left of the screen, this 64.4%, is the percentage of people with acute hepatitis A who have reported homelessness and or injection drug use. And kind of in keeping with what that demographic looks like here in King County, most folks have been, in the 30 to 40-year-old range, predominantly white and predominantly male. So many of you may have taken care of some of these patients with acute hepatitis A. And you know that the clinical syndrome is rather nonspecific. You present with sort of nausea, vomiting, and abdominal pain, fever, fatigue. Sometimes people can have loss of appetite. And you notice on labs that they have marked elevated transaminases. They may have jaundice on physical exam, and they may have dark urine or clay-colored stools. And on laboratory evaluation, in addition to elevated ALT, really the diagnosis is made by checking for a hepatitis A IgM. So this is a little bit of a confusing slide, but I want to walk you through it here. This kind of outlines what happens from a laboratory perspective during acute hepatitis A infection. So about 1 to 2 weeks after exposure to the virus, you start to develop IgM against hepatitis A, and you will become viremic and will be shedding virus into the stool. As you get into about week 3 to 4 after exposure to hepatitis A, you'll see a spike in your ALT and also have high levels of anti-IgM to hepatitis A. And that's really kind of the diagnostic marker that you're looking for in a compatible clinical syndrome. And then, weeks 4 to 5 to 6 after exposure, you'll start to develop IgG against hepatitis A. So it is possible for someone to be Hep A, IgM, and IgG positive at the same time. But really that IgM positivity in the right clinical scenario is indicative of an acute infection. As many of you know, the treatment for hepatitis A is typically supportive, as the infection is most often self-limited. As evidenced by our epidemiologic data here in King County, there's a pretty high degree of morbidity, but only about a 1% mortality, and most patients completely recover in about 3 months or sooner. For folks who have had high-risk exposures for hepatitis A, there is kind of post-exposure prophylaxis that usually involves giving the exposed person the hepatitis A vaccine. And in elderly folks and in immunocompromised folks, you can also give the hepatitis A immune globulin. And I think that the main point about Hep A, though, that I want to drive home is that we are having an outbreak here, and this is preventable. And so many of you are in clinics where you take care of folks who are marginally housed or who may have substance use disorders. And it's really critical that you vaccinate your patients against hepatitis A. The hepatitis A vaccine is incredibly effective. It's a 2-dose vaccine. It's given at 0 and 6 months, and it's greater than 95% effective in adults. And even actually getting just 1 shot in confers about a 90% protection. So even if you can just get that 1 shot in, that is helpful. And I usually just, in patients who are at high risk, I just vaccinate. I don't even check for IgG because sometimes these folks have kind of poor follow-up, and it's best to just get vaccine in them when you can. And the last thing I'll just say about hepatitis A, you may have heard this if you've rotated recently at Harborview. There have been a few cases of acute hepatitis A amongst previously vaccinated HIV positive folks who have documented Hep A IgG positivity. This has been reported to Public Health Seattle King County, and my understanding is that they're coming out with some forthcoming guidance on whether or not we should be revaccinating or how to manage these patients. This has really been limited to HIV positive individuals and not HIV negative individuals, but just something to keep in mind. If you do see a patient with a clinical syndrome compatible with acute hepatitis A and they're HIV positive, but they've been previously shown to be hepatitis A IgG positive, there's still a chance that they could have acute infection. And I think we're going to learn more in the coming months to years about the durability of vaccine protection in this population. So this is my cue to say that's all I'm going to say about hepatitis A. Are there any questions before I move on to Hep B? Okay, I'll take that as a no. Great, so let's move on to hepatitis B. I think, Hep B is the kind of the most confusing and hardest of the common viral hepatitis. Hepatitis B is a partially double-stranded DNA virus. There's 8 different genotypes that don't really matter all that much for treatment. And Hep B contains what's called a covalently closed circular DNA. It's also known as CCC DNA. And this exists within the nucleus of infected cells, kind of as a plasma-like molecule, and serves as a template for Hep B RNA. And this CCC DNA is really not well attacked or addressed by the antivirals we have for hepatitis B. So this kind of acts as a reservoir, if you will, of hepatitis B within the hepatocytes, and it makes hepatitis B very challenging to achieve a pharmacologic cure. So similar to hepatitis A, the burden of hepatitis B is really shouldered by countries outside of the United States. The countries in yellow and orange and red here, that means that they have a greater than 8% seroprevalence of hepatitis B, with some countries reaching in kind of the Western African region reaching up to about 13% seroprevalence. Although I will say, just by the numbers, China has the highest number of folks infected with hepatitis B, and a lot of the people that we see in our hepatitis and liver clinic here at Harborview have immigrated from China or parts of Southeast Asia where they've been perinatally infected with hepatitis B. Although, yeah.
I have a quick question, if that's right, about the prevalence. Is that all driven primarily by vaccination rates, or why is this? What's the thought behind this geographic distribution?
Yeah, I think, good question, Michaela. So I think a lot of it's driven by perinatal infection and low rates of birth dose vaccination. So there's actually it's been a challenge at the global level to roll out birth dose vaccination. That's something that's very routine here in this country, where basically within the first 12 hours of birth, a baby is given the first shot of hepatitis B. Even in the absence of immune globulin, which we give here for babies who are born to Hep B positive moms, the hepatitis B birth dose vaccination and subsequent, completion of a 3-shot series is actually quite effective in preventing perinatal infection. And folks who acquire hepatitis B perinatally are much more likely to go on to chronic infection as opposed to people who are infected as adults. So I think a lot of the folks that we see who are coming at least to seek care here in our clinical settings in the United States, who come from other countries where the Hep B prevalence is higher, have been infected at birth. And it's really from a kind of a prior lack of public health response for birth dose vaccination. Does that answer your question?
Yep, thanks.
Cool, great, yeah. So, thankfully here in the United States, we've seen a decreasing incidence of acute hepatitis B, really dating back to 1985. The Hep B vaccine became routine, I think in the late 80s, early 90s. And that's corresponded with a nice decrease in the incidence of acute hepatitis B here in the United States. Although I will point out is if you look at kind of 2012 onward, you see these slight upticks in the purple and the brown lines, which correspond to folks in their 30s and 40s, with a slight uptick in acute Hep B cases. And that's thought to probably be related to injection drug use and risk factors related to that. So risk factors for hepatitis B are very similar to that of HIV in that you can get it through contact with infected blood. Oftentimes in this country that's related to injection drug use, but it could be due to hemodialysis, unsafe tattoo practices, organ transplantation. There's also a risk with sexual exposure. Of course, that goes up when you have multiple partners. And then, globally, as I was mentioning, the vast majority of people with chronic hepatitis B were infected at birth. Usually this occurs intrapartum as opposed to transplacentally. It's mainly an intrapartum transmission. And thankfully, with birth dose vaccination and HBIG, or the Hep B immune globulin, we can reduce the risk of perinatally acquired hepatitis B by over 90%. And breastfeeding is not a significant risk factor for hepatitis B. So clinical features of Hep B, this can have both kind of acute and chronic manifestations. So the incubation period is typically anywhere between like 2 to 3 months. And patients, when they get infected with hepatitis B, can have an acute viral hepatitis that can present similarly to hepatitis A. People who are infected with Hep B as an adult or as an older child tend to have a higher incidence of acute kind of manifestations, whereas people who are infected at birth tend to not have that kind of acute presentation. And as I was just mentioning, chronic infection is something that can be lifelong in many patients, and it's much more common in people who acquire hepatitis B either perinatally or before the age of 5 years. And if you do have chronic hepatitis B, there's a higher rate of premature mortality due to liver disease, both from cirrhosis, but also from hepatocellular carcinoma. And the graph I'm showing you here is from a prospective cohort study in China, where they looked at mortality for hepatocellular carcinoma in patients with chronic hepatitis B. And the blue line is in patients who were screened for hepatitis B, and you can see that a higher proportion of those were alive at 5 years after diagnosis with HCC. And then the green line here is those who didn't undergo screening for hepatocellular carcinoma. So we know that people with Hep B get HCC at much higher rates. In fact, this study found that the relative risk of HCC mortality was 18.8 for men and 33.5 for women. So they have a very high risk of HCC. But we also know that if we can screen for HCC and we can diagnose this early, that HCC becomes much easier to treat. And oftentimes people can just undergo radioablation with like Y90 therapy. But if HCC is caught late and has already metastasized, then it is very challenging to treat and has a high mortality. So just a plug to, if you have a patient who has chronic hepatitis B, make sure that they're getting their HCC screening. There's a few guidelines that I won't go into about who qualifies for HCC screening, but pretty much it's based on race and age. And if you have anyone over the age of 50, for sure, regardless of their race, they should be undergoing Q6 month HCC screening, usually with an ultrasound and an AFP. The AFP is a little bit controversial, but that's what we do in the liver clinic. And I think, one of the kind of most challenging aspects of hepatitis B, particularly for a lot of folks who don't, do viral hepatitis that often, is just the serologies and like the diagnosis and what do these serologies mean. And I put this chart up here kind of mainly for your reference. This is actually taken from a new site called hepatitisb.uw.edu. I've got the URL at the end of this presentation. And it's, if any of you know the Hep C online site by David Spock and his group, this is the same sort of thing out of the same group here at UW for hepatitis B. So it's a really great resource. And this table here is just showing interpretation of test results for hepatitis B infection. So if you have a patient, for example, who has a Hep B surface antigen that's positive and a Hep B core antibody that's positive, what does that mean? And then you can kind of go over to the interpretation and you're like, okay, that probably means chronic infection. So I guess what I would say, just to kind of summarize this slide, is there's a few key things to know about the different serologies. So anybody who's got a hepatitis B surface antigen that's positive, that's somebody who has active or chronic hepatitis B. It could be acute hepatitis B or it could be chronic hepatitis B, but that's someone who's usually infected with hepatitis B. If somebody has a core antibody that's positive, that means that they have been exposed to hepatitis B in the past, and they may or may not have chronic infection. You determine that based on their Hep B surface antigen and their Hep B DNA. And then if somebody has a Hep B surface antibody, that can be positive either because they've had prior infection and have mounted an antibody response, or it can be positive because they've been vaccinated. So if you're not comfortable with the serologies, it's always helpful to go to a table like this when you get your results back on one of your primary care patients, and just kind of with time get comfortable of surrounding interpretation of those antibody results. And I think the other big challenge with hepatitis B can be management. What do I do with my patient who has chronic hepatitis B? Because not everybody actually needs antiviral therapy, and the decision about when to treat can be complicated. This is just another figure that I took from the Hepatitis B online site. And this comes from some expert guidance that was developed for primary care providers from a group of hepatitis B experts. And with the goal of trying to simplify things a little bit in terms of demystifying this when to start therapy for hepatitis B. And so you'll notice that kind of the guiding principle here in terms of a decision to start Hep B therapy is really based on the presence of cirrhosis, the Hep B DNA level, and their ALT level. So anyone with chronic hepatitis B who has cirrhosis should be on therapy and should never come off therapy. That's somebody who needs treatment for life. So it's pretty easy in that particular case. Somebody who does not have cirrhosis, then the decision to start treatment really depends on whether or not their hepatitis B DNA is elevated and their LFTs are elevated. So if you've got a patient with no cirrhosis, but who has a hepatitis B DNA level greater than 2,000, and they have elevated LFTs, that's somebody where you would want to start therapy. And then you monitor kind of their treatment response with LFTs, hepatitis B DNA, and some other labs, including the hepatitis B E antigen and E antibody, which I think is a little bit beyond the scope of this talk at this point, every 6 months. If they have an elevated DNA level, but they have normal LFTs, then that's someone that you can just monitor. And if they have a hepatitis B DNA level less than or equal to 2,000 in the setting of elevated LFTs, you really want to kind of go searching for other reasons why their LFTs might be elevated. See if there's any co-occurring viral hepatitis. Is there autoimmune hepatitis? Are they drinking? Things like that. But you can continue to monitor and don't necessarily need to start treatment. And then, of course, if their Hep B DNA is low and they have normal LFTs, then that's also somebody that you can just monitor. Treatment for hepatitis B has evolved, as has treatment for hepatitis C. And really the main drugs that we use today are entecavir, tenofovir disoproxil fumarate, or TDF, and tenofovir alafenamide, or TAF. So TDF and TAF are drugs that we also use for HIV. Entecavir has some mild activity against HIV, but it's nothing that we would ever use to treat HIV. So just to say that if you do have a patient who's Hep B positive and who's being considered for treatment, it's really important to evaluate them for HIV as well, because that can have some implications for how we treat them. And these are all oral pills that you take daily. The entecavir should be taken on an empty stomach, which can sometimes be challenging for patients, whereas the tenofovir drugs don't have to be taken on an empty stomach. And, once you start somebody on treatment for hepatitis B, it's oftentimes lifelong. As I was mentioning, persons with cirrhosis should be treated kind of indefinitely. And then the decision to, stop therapy in people who have a good treatment response really depends on some other serologic factors, including their hepatitis B E antigen, which is kind of a marker of infectivity, and their hepatitis B E antibody. And I just leave this up here kind of, if you're interested, you can take a look at this guidance from the primary care group on the hepatitis B site, but I won't get into those details today. And just, another plug, similarly with hepatitis A, we do have a vaccine, as you know, for hepatitis B. And you can see that really with the advent of the hepatitis B vaccine and the wide dissemination of the hepatitis B vaccine here in the United States, there's been a pretty dramatic drop in acute cases of hepatitis B. So this remains our kind of best tool for prevention of hepatitis B. And just a plug to please, vaccinate your patients for hepatitis B if they are not already immune. There are several vaccines to choose from that can sometimes be confusing. So Recombavax and Engerix are your typical single antigen 3-shot series Hep B vaccines. Twinrix is the hepatitis B, hepatitis A combo vaccine. It's also 3 shots. And Heplisav-B is kind of the newest kid on the block. It is a hepatitis B vaccine with a novel adjuvant that has a higher degree of, there's more seroconversions with the Heplisav-B, and it's only 2 shots. So, if your clinic has that available, that's not a bad option for folks. I will say that there has been some concern about sort of increased cardiac events after Heplisav-B. I think that data is still a little bit sketchy, but somebody who has significant cardiac disease, you may consider avoiding Heplisav-B and just choosing the Recombavax, Engerix, or Twinrix, depending on whether or not they need a vaccine as well. So again, my cue to say that we are done with hepatitis B, and we're going to move on to hepatitis C, but are there any questions before I do that?
Mac, you had a question there asking where is that? Just to clarify, Mac, where is what? Oh, the photo. Oh, okay.
Oh, this photo. This is actually taken from, it's called the Zugspitze. It's in Germany. It's the highest kind of peak in Germany. And I went there pre-COVID. There's a nice little like igloo hotel right here, which is kind of cool. It was very cold in there. I did not stay there. And then they have this very cute, like very, Alps European church up here, and a nice little lodge area. So just, it's a nice, on a smoky kind of COVID-y day, it's a nice visual to think about. All right, so let's talk about hepatitis C in the kind of last bit of time that we have. So hepatitis C is a single-stranded RNA virus, part of the Flaviviridae family. There's 6 main genotypes of hepatitis C, and genotype 1 accounts for about 70% of infections that we see here in the United States. The genotypes of hep C used to matter a lot for treatment decisions, less so now that we have pan-genotypic regimens, but still can, still can predict some response to treatment. Hep C is the leading cause of liver transplantation still in the United States, although some folks project that NASH, or non-alcoholic steatohepatitis, will overtake Hep C in the coming years. And it is transmitted primarily through blood-to-blood contact, and as you know, there's no vaccine. So hepatitis C prevalence by country, Egypt actually has one of the highest prevalences of hepatitis C in the world, and part of that is related to a schistosomiasis treatment campaign that was undertaken several decades ago, where they I actually don't know what drug they were giving IM, but essentially they were giving an IM drug to folks along the Nile River because there were high rates of schistosomiasis, and the thought that it was that there was a high rate of iatrogenic hepatitis C transmission. Mongolia and parts of Asia also have a pretty high seroprevalence of hepatitis C, as do areas in kind of the Middle East. Pakistan actually has a very high prevalence, as does the Republic of Georgia. And here in the United States, historically hepatitis C has been highest among the baby boomer generation. And so there's been guidelines for quite some time saying to screen people who were born between the years of 1945 and 1965. Although we've been seeing climbing rates of acute hepatitis C, particularly among younger age groups. So this graph is from the CTC, and what you can see is really starting in 2010 here, there was a marked rise in acute hepatitis C cases in people who were 20 to 29 years of age and 30 to 39 years of age. And a lot of that, of course, is felt to be related to the co-occurring epidemic of injection drug use. So this data is a little bit old here, but this is showing change in incidence of hepatitis C amongst young people who inject drugs from 2006 to 2012. And what you can see is that the states who are highlighted in red, including Washington state, have seen a greater than or equal to 200% increase in the incidence of hepatitis C amongst young PWID. And in Washington state, we are seeing, in King County in Washington state, we're seeing, very high rates of hepatitis C. So this is data that was published last year in the Seattle Times, showing that in Washington state, which is here in the purple bars, we've seen a 31% increase in prevalent cases of hepatitis C from 2009 to 2017. And in King County, there's similarly been, King County saw a 31% increase in prevalent cases, and Washington state saw a 60% increase in prevalent cases, really between 2009 and 2017. So a huge increase. And we're also seeing an increase in acute hepatitis C cases at the state level, with really the highest number of reported cases in recent history occurring in 2018. So this remains a problem close to home. And as most of you know, the risk factors for hepatitis C primarily center around blood-to-blood contact, with injection drug use being, by far and away the highest risk for hep C here in the United States. There's also risks related to non-injection drug use, so sharing of cocaine straws if you have kind of blood contaminating the straws, unsafe tattooing and piercing practices, blood transfusions prior to 1992 when we started screening the blood supply, and then receipt of clotting factors prior to 1987, and then organ transplantation, especially now that we're doing hep C positive organ transplantations. Sexual transmission of hep C is a little bit more rare. It's more commonly reported among men who have sex with men, but can, in very rare instances, be potentially transmitted heterosexually, although it's like I said, very uncommon. And there's approximately 5 to 6% transmission rate from mother to child when the mom's HCV positive or HCV RNA positive. So hep C is predominantly a chronic infection. You can see symptomatic acute hepatitis C, but it's much less common than acute hep A or acute hep B. After folks are exposed to hepatitis C, there's a certain proportion, usually around 20%, that might clear the virus on their own. So they'll remain hep C antibody positive, but they will be RNA negative. But the vast majority of people go on to develop a chronic infection. Of those, approximately 5 to 20% go on to develop cirrhosis, and approximately 1 to 5% go on to develop end-stage liver disease, HCC, and may require a transplant. And this is really a slowly progressive process. It happens over 20 to 30 years, but it can be accelerated by things like co-occurring hepatitis B, co-occurring HIV, or alcohol use. So if you do have a patient on your primary care panel, or if you're seeing somebody in the hospital who has hepatitis C, it's really important to screen them for hep B, screen them for HIV, and counsel them on the importance of alcohol cessation if they are still drinking. Testing for hepatitis C used to be sort of age cohort based, as I was talking about with the baby boomers, but now there are new recommendations for one-time routine testing for hep C antibodies in all adults. So really everyone you're seeing in clinic should be screened for hepatitis C regardless of risk factors. And that's a new recommendation in the past year or so. Once you've diagnosed someone with chronic hepatitis C, so they are antibody positive and they're RNA positive, then really they're eligible for treatment. We want to treat everybody who has hepatitis C, regardless of substance use, regardless of their social circumstances. We really want to be able to get them treated because we have a high probability of being able to cure them. And one of the things you'll probably, you've probably heard about or maybe have done in your clinics is trying to assess the degree of fibrosis after a hep C diagnosis. So is this somebody who has Hep C but doesn't really have much scarring in the liver, or is this somebody who has Hep C and actually has cirrhosis? And that is important, one, because there are some slight differences in how we may treat somebody with direct-acting antivirals, and it also helps inform you as to whether or not they need screening for hepatocellular carcinoma if they are cirrhotic, or if they need an EGD to screen for varices, for example. So there are both non-invasive ways to screen for fibrosis, and then there's more invasive ways like a liver biopsy, which remains the gold standard. From a non-invasive kind of lab perspective, there are certain calculators that can help assess the degree of fibrosis. So there's the APRI calculator, which is the AST to platelet ratio, and then there's the FIB4 calculator. Both of these can be found on the UW Hepatitis C online site. They can also be found on the UW Hepatitis B online site, or just you can Google them. And the AST really takes into consideration someone's AST and their platelet count to give you a score that kind of prognosticates their degree of fibrosis. So really anything that's 1.0 or greater has a high probability of, or has a sensitivity, I should say, of 76% and a specificity of 72% for predicting cirrhosis. And then for your FIB4s, that takes into account your age, AST, platelet count, and ALT. And a score of greater than 3.25 has a 97% specificity and a positive predictive value of 65% for advanced fibrosis. You may also see folks send off a test that's called the FibroSure. This is a non-invasive blood test that uses a proprietary algorithm based on several factors to kind of give you a score that correlates with the level of fibrosis. And oftentimes we'll use this in conjunction with another non-invasive lab test like an APRI or a FIB4 to see if you have concordance between these two tests in terms of the patient's degree of fibrosis. But more often than not, what we do at the liver clinic is a FibroScan. So a FibroScan is a kind of special type of ultrasound that basically can help measure the stiffness of the liver. This is a little bit different than what our scan looks like in hepatitis and liver clinic, but you kind of get the picture. You have this probe here that you place on the patient's right side, and you take at least 10 different measurements. It just kind of provides a little tap to the patient's side when the sound wave goes through, and it will spit out a score that correlates with the degree of liver stiffness and scarring. And there are certain cutoffs that indicate whether or not they have cirrhosis or just advanced fibrosis, but no cirrhosis, or if they have low-level cirrhosis. And this is something that's quite easy to be done. It's not painful, non-invasive, has been well validated. And if you want this to be done, but you want to actually treat your patient for hepatitis C yourself in your own clinic, we can actually do this for you, just a FibroScan only at the liver clinic, and you can put in a referral to the hepatitis and liver clinic at Harborview for a FibroScan only. So just something to keep in mind. In terms of treatment for hepatitis C, as you know, there has been really a huge revolution in Hep C treatment over the past few years with the advent of direct-acting antiviral therapy that confer a 95% chance of cure. Prior to that, we were using interferon and ribavirin, which made people feel terrible. You had to give yourself shots for a whole year. Ribavirin would give people anemia. And it was just really terrible because it only had about a 50% chance of curing folks. And now we can give them, oral pills for 2 to 3 months and have a 95% chance of cure. So I just want to go over 2 of the main hepatitis C drugs that we use. So one is called Epclusa. This is sofosbuvir velpatasvir. It is a pan-genotypic direct-acting antiviral, so meaning it treats all genotypes of Hep C. It is produced by Gilead, and is the wholesale cost is almost $75,000. It's given for a 12-week course. So you take one pill once a day for 3 months. Pretty low side effect profile and has a 95% chance of cure. The other drug that we use a lot here in Washington State, because it's preferred by Washington State Medicaid, is Mavorite or glecaprevir pibrentasvir. This is produced by AbbVie and has a lower wholesale cost of just about $26,000 for an 8-week course, but still incredibly expensive. It is also pangenotypic. This is a drug that you give 3 pills once a day, usually for an 8-week course, although sometimes if we're treating someone with cirrhosis, we oftentimes extend to a 12-week course. Both Mavorite and Epclusa have pretty low side effect profiles. Most oftenly, my patients will tell me they were fatigued or they had like a headache or maybe they felt a little bit nauseous. But by and large, these medicines are very well tolerated, and I've never had somebody stop their direct-acting antivirals due to toxicity. And of course, the goal of Hep C treatment is achieving a cure, or what we call a sustained virologic response at 12 weeks. That's when you basically have an undetectable RNA level 12 weeks after stopping therapy, and that we consider to be a functional and durable cure. I will say, you know, I talked at the beginning of this talk about the WHO elimination targets for hepatitis C. And it's great that we have these new drugs and they're so well tolerated and they're so effective. But we're still not getting them to the people who really need them. Or at least there's a lot of work still to be done. So just to kind of conclude this talk, I wanted to show a slide from some local data that was obtained from people who inject drugs here in Seattle. And this is showing the care cascade for hepatitis C amongst PWID here in Seattle in 2018. So as you can see, amongst the 100% of folks who screened positive for hepatitis C, so it's 376 people, 94% had been tested in the past. And so we're doing actually a pretty good job of testing. And 68% of those had been told they had hepatitis C, with an additional 7% being told that they had cleared the virus. So we're actually doing a decent job of testing people and diagnosing them. But only 20% of those who had been diagnosed with hepatitis C had actually been treated, and only 19% had been cured. So I think take-home message here is just that we have a long ways to go in really reaching the people who are in most need of treatment for Hep C and getting them cured. So with that, I will end, and we'll have just under 15 minutes, it looks like, for questions. I wanted to give you guys some resources here. So this Hepatitis C online website and the Hepatitis B online website are produced here at the University of Washington with funding from the CTC. Really great resources for Hep C and Hep B treatment. And then there's a couple other resources just for kind of epidemiologic data from the CDC, from IHME, and then WHO. So with that, I will end and see if there's any additional questions. Let me stop my share.
Hey, Maria, it's Michaela again.
Yeah.
What advice do you have for primary care docs about what hepatitis B and hepatitis C things that primary care docs can handle versus when they should think about referring to you guys? Or are you guys open to anyone? Or when are they good on their own versus when they should think about referring to hepatitis clinic?
Yeah, great question. I think it depends on, you know, your comfort level with treatment of either hepatitis B or C, and kind of the support in your clinic. You know, Hep C therapy is not, you know, it's not terribly challenging. And this, you know, it's a short course, side effects are low, but I think, you know, a lot of folks, if you haven't done it before, if you've never been taught how to do it, or there's, you know, your attending doesn't know, you know, how to treat hepatitis C, you know, we are obviously happy to see those folks in hepatitis and liver clinic. But I think ultimately the goal is to get more Hep C treatment done in the primary care setting. So I think it, it really depends on one's level of comfort. Certainly if somebody has a decompensated cirrhosis, that's somebody who should probably be seen by a hepatologist or by a liver specialist. And if, for folks who are interested in treating hepatitis C in their clinics, but who might need a little bit of extra support, there's the Project Echo Hepatitis C that's from noon to 1:30 on Tuesdays. And that's where you can kind of present your cases to an expert panel and receive advice on what to do. And that's been really effective for primary care docs in the community. In terms of hepatitis B, I think it's also kind of dependent on the provider's comfort level and, their ability to kind of follow the patient every 6 months for liver function tests, Hep B DNA, those types of things, make sure they're getting their liver ultrasounds. Certainly if somebody is on like immunosuppressant drugs, or if there's, co-occurring HIV, things like that, things can get really complicated, and that might be a person that you want to have a specialist involved with. And so I think, again, it just kind of depends on the comfort level. But these are things that theoretically can be managed in the primary care setting if the provider feels comfortable and kind of feels like they have enough training in that area.
There was actually another question from Paul Bordelon. How much, I'm assuming, Paul, correct me if I'm wrong here in reading into this question, but how much should we try and get the Heplisav vaccine if our clinic doesn't necessarily hold that one versus the older vaccines?
Yeah, I think, if you're vaccinating somebody for the first time, I've been using Heplisav if it's available, for my kind of standard run-of-the-mill folks. If it's not available, I think it's perfectly fine to vaccinate with the 3 vaccine series, the Recombavax or Engerix, or Twinrix if they need a hepatitis A vaccination as well. I think, really the goal is to get them vaccinated. If somebody's a Hep B non-responder, you may consider, like if they've received a 3-shot series and they didn't seroconvert their surface antibody, while there's no like actual guidance on this, some have suggested, revaccination with Heplisav to be an option for those non-responders. So that's somebody where I might, push a little bit more for it if they've already not responded to the 3-shot series. But I think, if your clinic doesn't have it, I would give what your clinic has. The most important thing is to get vaccine into them. I know that pre-transplant, they're trying to do Heplisav because that's where we really want people to be protected against hepatitis B. And since there's some, evidence for higher seroconversion rates with the Heplisav B, that's what they've been doing over at the U. Any other questions I can answer for you guys?
I had a 1 or 2 questions actually. Mm-hmm. One of them, you mentioned that we were going to kind of, or you mentioned very purposely kind of not going into the hepatitis B virus E or the envelope antibody as much in how we use it. If you have somebody who's E antibody positive and then loses that positivity, is that a in that 6-month intervening period or monitoring period, does that have prognostic significance?
Yeah, E antigen and E antibody are kind of can be challenging and confusing. And E antigen is really it's sort of a mark. You can think of it as like a marker of infectivity and viral replication. So moms, for example, like pregnant women who have a positive E antigen are much more likely to transmit hepatitis B to their newborn than moms who are not E antigen positive, just because there's a higher degree of viral replication, a higher degree of sort of infectivity. People who seroconvert their E antigen to their E antibody, that can be a marker of some degree of immune control, but doesn't necessarily mean that they're going to clear their hepatitis B. But one of the things that we look for when we're monitoring people on treatment is if you were e antigen positive to begin with, and then you convert to being e antigen negative and e antibody positive, that's a sign that like, oh, maybe your body is getting some degree of immune control, and you can, if things stay stable for the next, year or so, you can actually consider in the right patient who's non-cirrhotic, whose LFTs are normal, whose DNA is negative, to actually stop treatment in those cases. But it can be tricky because sometimes people flip back and forth. So they can be e antigen positive and then convert their e antibody, but then they can flip back. And so that's a case where you kind of just want to ride it out and wait and see what happens. If somebody's e antigen negative and e antibody positive when you start treatment, oftentimes those folks just stay that way, and it's hard to really monitor any degree of like immune control. And so those people tend to be on therapy lifelong. I know the primary care guidance group, some of the figures that I referenced really tried to get away from e antigen and e antibody in their treatment guidelines, at least for initiation of therapy, just because it's very confusing. It's like one other thing to kind of monitor. Although I do think that if you are considering stopping treatment in somebody, those things really do become important.
Thank you.
Mm-hmm.
When we have another question from Paul, how does your practice vary for patients born in hepatitis B endemic areas in terms of vaccination? For example, how in significant others, or sorry, Paul, if I'm misreading this abbreviation, but in the setting of hepatitis B or antibody, but not hepatitis B surface antibody.
Yeah, great question. So what to do with an isolated core antibody? That's, I think challenging for many people. Most of the time, if somebody has an isolated core antibody, that means that they have been infected in the past, but just didn't really mount a response to seroconvert their S antibody, or they've lost that S antibody. In run-of-the-mill patients who are HIV negative, we tend to not revaccinate. There's no guidance to revaccinate isolated cores. And that's because the thought is that if they are exposed to hepatitis B again, they'll have this kind of amnestic response to the virus and be able to mount an immune response. The one area where that differs is if you have an isolated core antibody in an HIV positive person, then the HIV vaccination guidelines would recommend to vaccinate them. So in my Madison clinic patients, I vaccinate isolated cores. But if I see an isolated core in liver clinic, when I'm treating Hep C, I don't revaccinate that person. But yeah, good question. Anything else? All right. Oh, I think Alex, you're on mute.
It's not a Zoom conference that I run with, if that doesn't happen at least once.
Yeah.
So thanks so much for a really great talk. We all learned quite a bit. There should be a QR code that goes out.
Oh shoot, sorry.
No, that's okay.
I was asked to include that in the slides, and I didn't.
That's okay. I will be emailing that out to everyone shortly. And then for those who signed off, if you can remind your co-residents to fill that one out quickly. And again, if there's questions afterwards, I'm sure that we can try and get answers to those as they come.
Yeah, no, I'd be happy to answer things. And if you have questions about your patients or things like that, or questions that come up, feel free to email me.
Perfect.
Great.
Well, thanks again.
Thanks, guys.
And everybody have a good Monday.
Bye.